A chronic inflammatory disorder of the airways leading to reversible airway obstruction. Chronic inflammation causes an associated increase in airway hyperresponsiveness and leads to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Symptoms particularly occur early morning or at night. Epidemiology. The UK has one of the highest rates of asthma worldwide. An estimated 5.4 million people in the UK are receiving treatment for asthma. The cost of the disease is substantial, costing $3.7 billion a year. Asthma prevalence in children is approximately 10%. In the UK, one person every 8 hours dies from asthma. 90% of these deaths are preventable. IgE. Immunoglobulin E, IgE, is a class of antibody, or immunoglobulin, Ig, isotype. IgE plays an essential role in type I hypersensitivity, which presents during various allergic diseases, such as allergic asthma, sinusitis, allergic rhinitis, food allergy, chronic urticaria, and atopic dermatitis. IgE also plays a pivotal role in allergic conditions, such as anaphylactic reactions to certain drugs, bee stings. IgE is present in minute amounts in the body, but capable of triggering the most powerful inflammation reactions. Role of IgE in asthma. IgE binds to allergens and triggers the release of substances from mast cells that can cause inflammation. When IgE binds to mast cells, a cascade of allergic reactions can begin. Allergen exposure. Repeated exposure to a particular allergen can be the first step in developing a reaction to it. T-cell action. Allergens induce T cells to activate B cells, which develop into plasma cells that produce and release more antibodies. Classification of asthma. Extrinsic, atopic, allergic. An external trigger can be identified. Childhood asthma. IgE mediated against common environmental antigens like house dust mites, pollens, spores, etc. Acute symptoms. Hereditary in 40–60% cases. Intrinsic, non-atopic. No obvious causative agent. Tends to occur after childhood. More chronic symptoms. Based on phenotypes. Examples are allergic, IgE, such as dust mites, non-allergic, such as pollution, aspirin-sensitive exercise, induced asthma, occupational asthma. Eosinophilic. Non-eosinophilic. Eosinophils are a type of white blood cell whose natural role is to defend the body against parasites. They also accumulate wherever allergic reactions take place, including allergic asthma. Eosinophils gather wherever there is a parasite infection or an allergic reaction, such as allergic asthma, and then release chemicals. The chemicals are very efficient at fighting parasites, but they can also harm the body if released in the wrong place, so the lining of the lungs becomes damaged in asthma. Precipitating factors. IgE related. Specific precipitating factors. Animal allergens. Labs, farms, flour, grains, farms, bakers. Enzymes, washing powders. Non-IgE related, non-specific precipitating factors. Isocyanides, spray painting, cold air and exercise, airborne irritants such as cigarette smoke, fumes and atmospheric pollution, irritant dust, vapors, and fumes, drugs, NSAIDs, aspirin, ibuprofen, Beta blocker. Infections of the respiratory tract. Emotional factors. Bronchial provocation test. Increased responsiveness of airways, as measured by a FEV1 PFR to stimuli such as inhaled histamine and methacholine. Forced expiratory volume, FEV1. FEV1 is the volume of air that can forcibly be blown out in 1 second after full inspiration. Peak expiratory flow, PEF, is the maximal flow, or speed, achieved during the maximally forced expiration initiated at full inspiration, measured in liters per minute or in liters per second. Pathogeneses. Allergen-induced asthma, atopic. Exposure to allergen. 1. A single exposure to an allergen causes a dual asthmatic response. 2. Repeated exposure to allergens leads to chronic inflammation and bronchoconstriction. Phases of an asthma attack. Acute or early phase response. Acute bronchospasm. Exposure to allergen results in bronchospasm and wheezing within minutes. Maximal effect reached within 15-20 minutes. Effect subsides after 1 to 3 hours. May then progress to late phase. Late phase response, inflammation, develops about 4 hours after the initial acute phase and may last for a further 6 to 8 hours. Characterized by eosinophilia in the mucous membrane, mucosal edema, and increased smooth muscle excitability, hyperresponsiveness. Airway obstruction with cough and sputum production. What occurs during a reactive airway disease episode? 3 changes. Increased mucus. Airways become irritated and inflamed, causing the cells in your airways to produce mucus. The thick mucus produced can clog the airway of your lung, making it difficult to breathe. Inflammation and swelling. Airways of your lungs swell and become inflamed. Muscle tightening. The smooth muscles in the airways of lungs tighten, and the airways become smaller, making it more difficult to breathe. Airway inflammation. Chronic inflammation causes airway hyperresponsiveness. Chronic inflammation in the airways involves a host of white cells, mast cells, eosinophils, lymphocytes, macrophages, etc. Hypersensitivity. Hypersensitivity is an immune response that occurs in an exaggerated form causing damage to host tissues. 4 types of responses. Type 1, allergy, immediate involving IgE. Type 2, cytotoxic hypersensitivity, antibody initiated. Type 3, immune complexes, between antibody and antigen. Type 4, delayed type, mediated by T cells and macrophages. Mast cell degranulation. Upon mast cell degranulation, arachidonic acid metabolites, e.g., leukotriene, prostaglandins, and cytokines release occurs. Histamine. Histamine is an organic nitrogenous compound involved in the inflammatory response. Histamine increases the permeability of the capillaries to white blood cells and some proteins to allow them to engage pathogens in the infected tissues. Histamine exerts its effects by binding to G protein-coupled histamine receptors, designated H1 through H4. Functions of histamine. Histamine elicits vasodilation, smooth muscle contraction, mucus hypersecretion, and edema as part of the immediate phase allergic reaction. Histamine also has significant immune pro-inflammatory properties that are mediated by numerous cell types, including macrophages, T lymphocytes, epithelial and endothelial cells and their products, and other key regulatory molecules. Cytokines. Cytokines are proteins that are produced by cells, critical elements of the immune response, and act as signal between cells. Cytokines interact with cells of the immune system in order to regulate the body's response to disease and infection. Role of cytokines in asthma, tumor necrosis factor, and interleukin, IL-4, IL-5, IL-6, IL-1B, and IL-13. Profound effects on vascular endothelium, like alteration of vascular permeability and adhesiveness. Allowing circulating inflammatory cells to adhere to the endothelium and to migrate into the surrounding tissue. Cell adherence. Mast cell progenitors must migrate from the blood into tissue sites. A crucial step in this process is the adherence of cells to the endothelium. Cell adherence is mediated by adhesion molecules and adhesion receptors on the surface of mast cells that can mediate binding to other cells and to extracellular matrix. TNF-A and IL-4 can modulate adhesion molecules on endothelial cells. Activated endothelial cells express the intercellular adhesion molecule, endothelial leukocyte adhesion molecule 1, and vascular cell adhesion molecule on their cell surface. Human mast cells express integrins as receptors for these molecules. IL-4, IL-5, and IL-6 stimulate the proliferation and differentiation of activated B cells and induces class switch. IL-5 is also very important in stimulating growth and differentiation of eosinophils. Other mast cell mediators. Mast cells produce several neutral proteases, including tryptase and chymase, that damage and activate the bronchial epithelium, contributing to airway wall remodeling. Mast cells are key players in host defense, with a role in immune surveillance, phagocytosis, and immune activation. Airway remodeling. Tissue remodeling is a characteristic feature of asthma. The mechanisms between mast cells and fibrosis such tissue remodeling are unclear. Mast cells may have a substantial effect on tissue remodeling, especially in the airway, on smooth muscle hypertrophy, and on mucus hypersecretion. By releasing proteases such as tryptase and growth factors. These cells also have an effect on epithelial damage and on basement membrane thickening in patients with allergic asthma. Mast cell degranulation clinical characteristics. Ongoing mast cell activation in asthma is a characteristic of the chronic inflammatory nature of the disease. Activation is detected by elevated levels of tryptase and PGD2 in bronchoalveolar lavage (BAL). Clinical characteristics. Higher spontaneous release of histamine by mast cells obtained from the BAL of asthmatics than observed than those obtained from non-asthmatics. Ultrastructural analysis of mast cells in lung tissue also shows that asthmatics have more degranulation than atopic non-asthmatics.